The topic we are going to discuss today is toxoplasmosis, and we are going to discuss this topic quite at length since this is the most important parasitic infectus. Toxoplasmosis is caused by Toxoplasma gondii, an obligate intracellular protozoan. It is estimated to infest at least 10% of adult population in northern temperate countries and more than half of adults in Mediterranean and tropical countries. The cat is the definitive host, with intermediate hosts including mice, livestock, birds, and humans. A critical mode of human infection is transplacental hematogenous spread to the fetus. Occasionally, infection may be transmitted via. No. This diagram shows the life cycle of Toxoplasma gondii, and as you can see in this diagram, cat here is the definitive host, and it uh, excretes oocysts in the feces, and it either contaminates food, water, or soil. And intermediate hosts, rodents, mice, birds, and livestock are infested. And either via contaminated water. Cat litter disposal with subsequent transfer to food is a well-known potential mode of infection in humans. Though indoor cats have a low rate of toxoplasmosis infestation, the bradyzoid is an inactive stage for lying dormant within cysts and tissue, and it forms tissue cysts. Now, they stay inactive in the eye, brain, and skeletal muscle, and consumption of undercooked meat or egg from an intermediate host can lead to infestation of human. Now, these bradyzoids they can rupture to release tachyzoids in human, where the infection can either come from uh, the intermediate hosts via consumption or uh, through vertical transmission from mother to fetus or through transfusions or transplantation. So bradyzoids can rupture to release tachyzoids, the proliferating active form, stimulating an inflammatory reaction. Conceptually, it may be helpful to think of an acute phase and a long-term chronic phase of infection. During the later, the new retinochoroidal scar may form asymptomatically over the course of years or decades. The transplacental hematogenous spread to the fetus is a critical mode of uh, human transplacental infection, and in a pregnant woman with active or not inactive latent toxoplasmosis, this is usually primary infection in an immunocompetent host, but occasionally reactivation of latent infection. The later predominantly immunocompromised. Occasionally, infection may be transmitted via organ transplantation or blood transfusion. Toxoplasmosis is the most common identifiable cause for focal retinitis, which typically causes inflammation adjacent to the chorioretinal scar. Now, uh, the congenital toxoplasmosis is one type where the mother is often symptom free or has only mild constitutional manifestation. The severity of fetal involvement is related to the duration of gestation at the time of maternal infection, just like any other infection. tending to be more severe in the early pregnancy when fetal death may result, which is 10% of all congenital toxoplasmosis. Neurological and visceral involvement may be very severe, but many cases are subclinical, especially in the later pregnancy. Retinochoroiditis may occur in over 75%, leaving scars that are commonly a later incidental finding. So, here you can see this type of scars, like this one at the macula and in the peripapillary area here. These are seen later in life, and this in the peripheral area. Then is the postnatal childhood acquisition, which is probably account for over 50% of cases of childhood toxoplasmosis. As with adults, in immunocompetent individuals, this is usually subclinical. Ocular lesions are probably common but may not develop for years after the initial infection. Acquired toxoplasmosis in immunocompetent adults is subclinical in 80 to 90% of the cases, and cervical lymphadenopathy, fever, malaise, and pharyngitis are common features in symptomatic patients, but more serious systemic manifestations are rare. Early retinitis may occur in up to 20% of cases. And that retinitis may point us towards the diagnosis of toxoplasmosis. Uh, in immunocompromised patient, uh, it may be acquired or result from reactivation of pre-existing disease as well as the constitutional symptoms occurring in the immunocompetent meningoencephalitis, pneumonitis, retinochoroiditis, and a range of other features can occur. Toxoplasmosis is responsible for 20 to 60% of all cases of posterior uveitis, depending on the country surveyed. For example, 85% in Brazil. More than half of the quiescent uh, retinal lesions will have been acquired from postnatal infection. Reactivation at previously inactive cyst containing scar is the rule in the immunocompetent, although many represent new infection. First presentation with symptomatic ocular infection occurs at an average of 29 years, and that might be due to the fading immunity, fading acquired immunity, which is specific to the toxoplasmosis. Now, recurrent episodes of inflammation are common and occur when the cysts rupture and release hundreds of tachyzoids into the normal retinal cells. Ocular involvement from congenital infection may only be detected later in life with the incidental discovery of typical retinochoroidal scar, though occasionally macular or optic nerve damage may impair vision in childhood. Symptoms include unilateral acute or subacute onset of floaters, blurring, and photophobia. Other features on examination are spillover anterior uveitis, which is common. It may be granulomatous or resemble Fuchs uveitic syndrome. Elevated intraocular pressure may follow. A single inflammatory focus of fluffy white retinitis or retinochoroiditis associated with pigmented scar or satellite lesion is typical, uh, as this here may represent that satellite lesion, and lesions tend to involve the posterior core as they're seen here in the macular area. Then de novo foci, not associated with an old scar and multiple lesions, are relatively uncommon in the immunocompetent, but occur more frequently in the immunocompromised, as seen here. This is the scar, and there are those normal foci, the white ones. Vitritis may be severe and impair fundus visualization, uh, as here. As you can see, that fundus is barely visible here. Headlight in the fog is the classical description of the white retinal inflammatory neuritis viewed through vitritis. Um, Vasculitis may be arterial, but is more commonly venous. Arteries can be involved. Optic disc edema is also common. Then there is extensive and fulminant retinal involvement, which is generally confined to immunocompromised. In whom it may be bilateral and difficult to distinguish from viral retinitis. Retinochoroiditis may be absent in the acute phase of acquired disease, with activity consisting of anterior uveitis, vitritis, and retinal vasculitis, as already been discussed. Uh, Typical retinal scar may form later. Neuroretinitis, similar to that seen in cat scratch disease, is rare and may be a marker of acutely acquired rather than reactivated infection. Punctate outer retinal toxoplasmosis is an atypical manifestation featuring a cluster of small, 25 to 75 micron diameter, grayish-white lesions, and tend to occur in younger patients. Now, visual loss, causes of permanently reduced vision. Around 25% of eye include macular inflammatory lesions, edema, optic nerve involvement, and vascular occlusion. Vascular occlusion, as it can be seen, uh, periarteritis here in figure A, and also demonstrated in the fundus angiography, where there is extensive non-perfusion at the posterior pole, this completely dark area, and serous, rhegmatogenous, and fractional RD. Um, as it is seen here, this is the point, the arrows pointing towards the serous RD, this area, which is very clearly visible in angiography. And um, late secondary choroidal neovascularization, which is adjacent to an old scar here in this picture, more prominently visible on angiography. Now, recurrence, the average number of recurrent attacks per patient is 2.7, and within 5 years more than half may experience a further episode. Healing in immunocompetent hosts usually occurs spontaneously within 6 to 8 weeks. Although vitreous opacities take longer to clear, the inflammatory focus is replaced by a sharply demarcated atrophic scar that develops a pigmented border. So this picture here shows moderate activity, and this is following 3 months of antibiotic treatment, the scar formation. Diagnosis is usually based on clinical examination findings, but we can also include certain other tests. Uh, in serology, Toxoplasma IgG antibodies are detectable in the serum within 1 to 2 weeks of initial infection and indicate exposure to the organism at some point in the past, providing circumstantial evidence to support clinical suspicion. Uh, However, community uh, seroprevalent is high. At least a third of individual is most in most communities. Positivity to IgM antibodies usually means that infection has been acquired within the last year and helps to distinguish between acute, which is newly acquired, and chronic infection. It is a critical test if newly acquired infection is suspected during pregnancy. Occasionally, IgM is positive due to persistent or reactivation following earlier infection. PCR testing of intraocular fluid is variably sensitive, which is 16 to 67%, but highly specific and can be diagnosed in clinically uncertain cases. Aqueous and vitreous probably give similar yields. Ocular fluid antibody assessment, calculating the ratio of Goldman-Whitmer coefficient of specific IgG in aqueous humor to that of in serum seems to be a reasonably sensitive 48 to 90% investigation. Imaging OCT will demonstrate macular edema. B-scan ultrasonographic imaging can be used to exclude retinal detachment in the presence of severe vitritis, and fundus autofluorescence may facilitate monitoring of inflammatory activity. Now, treatment is quite long and difficult process. Active ocular toxoplasmosis is treated with antibiotics, but none of the current approaches has been shown to be better than another in respect of the final visual outcome, lesion size, or recurrence rate. Eradication of the parasite is difficult to determine, but parasite activity and multiplication may be reduced, leading to a decrease in size of the eventual retinochoroidal scar. The agents used have the potential for significant morbidity and as spontaneous resolution generally occurs, treatment is not administered in every case. Clear indications include a sight-threatening lesion involving the macula, papillomacular bundle, optic nerve head, or a major blood vessel, severe vitritis, and in immunocompromised. Treatment typically lasts for 4 to 6 weeks, and complete healing of active lesion occurs over a period of 4 to 6 months. Treatment of congenital toxoplasmosis in neonates with antimicrobials for 1 year may reduce the frequency of subsequent development of retinochoroidal scars. Now, first of all, we are going to discuss the most important drug, that is prednisolone steroid. 1 milligram per kilogram is given initially and tapered according to the clinical response, but should always be used in conjunction with a specific anti-toxoplasma agent, more frequently pyrimethamine combined with sulfadiazine, which is classic or triple therapy, sometimes supplemented with clindamycin. Some authorities start steroid only after 24 to 48 hours of antimicrobial therapy. Systemic steroids should be used with extreme caution in immunocompromised patients, and children should undergo varicella zoster vaccination if they have not had chickenpox. Next is the pyrimethamine, which is a folic acid antagonist that is believed to be highly effective. It is administered as a loading dose of 75 to 100 milligram for 1 to 2 days, followed by 25 to 50 milligram daily for 4 weeks, in combination with oral folinic acid and not folic acid, 5 milligrams 3 times a day, 3 times a week, to retard thrombocytopenia, leukopenia, and folate deficiency. Weekly blood counts should be performed in acquired immunodeficiency syndrome, which is AIDS. Pyrimethamine is avoided or used at a low dose because of possible pre-existing bone marrow suppression. and the antagonistic effect of zidovudine when the drugs are combined. Then comes sulfadiazine, which is given at a dose of 1 gram 4 times daily for 3 to 4 weeks and is usually given in combination with pyrimethamine. Side effects of sulfonamides include renal stones, allergic reaction, and Stevens-Johnson syndrome. Coming next to the intravitreal therapy with clindamycin, 1 milligram and dexamethasone 400 microns may be as effective as triple therapy in reactivated infection. 2 to 3 injections at 2 weekly intervals may be required. It may be preferred in recurrent infection in pregnancy, but would not generally be used in isolation in immunocompromised and newly acquired IgM positive infection. Systemic therapy has superior efficacy. Deposteroid, intra and periocular preparations such as triamcinolone should be avoided as uncontrolled progression has been reported. Then is azithromycin 250 mg to 500 milligrams daily shows evidence of reducing the rate of recurrence of retinochoroiditis, and its use in combination with pyrimethamine, folinic acid and prednisolone is promising new regimen. Clarithromycin may be a good alternative to azithromycin. Cotrimoxazole, trimethoprim 160 mg to sulfamethoxazole 800 mg twice daily in combination with prednisolone is a low cost and better tolerated option but might not be quite as effective as the classic therapy. Uh, Clindamycin 300 mg 4 times daily may be added to triple therapy or used instead of pyrimethamine. Pseudomembranous colitis is a potential adverse effect. Atovaquone theoretically attacks encysted bradyzoids but does not seem to prevent recurrence in vivo. Dosing is 750 mg 2 to 4 times daily. Topical steroids and mydriatic agents may be given for anterior uveitis. Antimicrobial maintenance therapy is used in immunocompromised patients. Uh, Vitrectomy may be performed in selected cases. As I have already discussed all of these scenarios. Now, the special case of pregnancy. Treatment of recurrent ocular toxoplasmosis during pregnancy should be chosen carefully and only started if absolutely necessary, as several of the drugs discussed have the potential to harm the fetus. Intravitreal therapy for reactivated disease or systemic treatment with azithromycin, clindamycin, and possibly prednisolone may be appropriate. Specific treatment to prevent transmission to the fetus is not generally given except in newly acquired infection, and urgent specialist management is appropriate. Spiramycin alone or in combination is commonly chosen. So that concludes our topic of toxoplasmosis. Toxoplasmosis is very important when it comes to ophthalmology. It is one of the most common cause of focal retinitis, and it is one of the most common parasites which infects and causes loss of vision due to multiple reasons. Most of the cases are monocular in clinical practice, at least what I from my own experience. So, if there is any more detail required, I will make another uh, lecture video of that and include my own experience in that. Thank you all for now. If you like the lecture, please subscribe and click the like button. Thank you all.